I'm Aundrea Cline-Thomas with ISPOR TV. The pharmaceutical industry is always evolving its strategy, and here to give us an update is Yannis Natsis. Thank you for being here, Yannis.
Thank you, Aundrea.
We'll start with, what are the main challenges of the EU payers?
Yes, to put it very simply, and I've been involved in this discussion for over a decade now, working in advocacy towards the European Union institutions, always advocating and championing for better and affordable medicines for all Europeans, for all patients. I would say that we are at a critical point. Why? Because we have this conundrum of very weak evidence. So we're not really asking the right questions from the manufacturers, combined with very high prices in certain cases of medicines. And why is that a problem? It is a problem because especially nowadays, given the political circumstances, the geopolitical situation, there are many national budget competing priorities, right? So, and with ESIP, my association that brings together social security institutions, so the broad spectrum of social protection that we still enjoy in Europe, we see that the budgets are really tight, and we have to provide for the European welfare states, which we still enjoy based on solidarity in Europe, and at the same time cover for new needs like security, defense. So you can understand that national budgets are squeezed, and at the same time we see that the medicines prices are soaring. So that is a problem. That is a problem of equity. It's a problem of sustainability for the system, because of course a healthcare system is not only medicines. It's not only the medicines expenditure. And that's why we are concerned, and we are trying to make the case for also on the European level of ensuring that we have affordable medicines, and that the affordability / the sustainability of the system, the affordability of medicines, remain on top of the EU political agenda.
So you said we're not asking the right questions. What are some questions we should be asking?
Correct. Thank you for this question. It is important to have more and better data early on in the marketing authorization process. Why am I saying this? Because the moment that the drug is approved and it's on the market, and of course in Europe it's a lengthy process because a marketing authorization does not equal direct access for patients. It has to go through negotiations. It has to go through health technology assessment. Of course, we're at an ISPOR conference. But if the data that we get at the time of the approval is very poor, and that's what we see this trend, which is really worrisome, then the life of the other links in the chain in order to get the medicine to the patient gets harder. So we need to ask for more and better data earlier on in the pre-approval phase, and at the same time strengthen the post-launch evidentiary requirements. In general, if I can put it in a very rather simplistic way, we need to raise the bar in order to enable also, for instance, the HTA authorities, the pricing and reimbursement authorities, to be able to do their job in a timely and effective manner.
And do you anticipate that the EU pharma legislation in its final form would address these problems that you've outlined?
There are indeed in the ongoing negotiations on the European pharmaceuticals legislation, which is it's a fundamental piece of legislation. It is an important legislative initiative. Will things change dramatically in the end, or drastically, if you wish? I'm not so sure. Negotiations are ongoing. I expect them to be lengthy because we're touching upon sensitive elements in the pharma legislation. And if I can tell you, the reason why we got to this point of having this conversation is indeed because also of the affordability debate. Because in Europe, we realized recently that these prices are unsustainable. So the affordability debate put everything else on the agenda. And we got to the point of having now this important piece of legislation being negotiated by the legislators. I'm optimistic that we will have better collaboration between, on what I said before, between the regulators, the HTA authorities, the pricing and reimbursement authorities, because at the end of the day, we're all playing for the same team, if I can put it this way, right? We all care for patients' access to evidence-based healthcare, timely access, and affordable access. Otherwise, we will have a problem with a broader social protection system that we enjoy in Europe.
Yannis, thank you for your insight. We really appreciate it.
Thank you very much.
Yeah. And now we're going to delve a little bit deeper into pharma legislation with Katja Murray. Thank you for being here. Will it be possible for the EU pharma legislation to address and provide incentives to solve both innovation and affordability challenges in the EU? Quite a big question.
That's a very big question. I think basically that's one of the big questions that the member states and the European Commission has been asking themselves when they were putting forward this revision. It will be difficult. And also, I think one of the difficulties is that with the revision, you're basically having some competences at an EU level. So some things the European Commission can decide. But then you also have the competences at a national level. So basically at the member state level. So I think when it comes to innovation, we actually quite recently did a study on innovation and you can say investors' willingness to invest in life science innovation in Europe. I think what came from that is very clear that there are various elements that influence innovation. I mean, one of them is also in the very early stages, if the European Medicine Agency can, make themselves available, offer advice on what are the type of studies, what are the protocols, what is the evidence. So you can say shortcut a little bit if you get that advice early on, then you know exactly how to design your trials at an early stage. So when it comes to innovation, there are different incentives. One of them is on the early advice piece. Of course, one of the key incentives is also that once you have a new treatment on the market, that you can protect your data and you can have, a time to kind of regain your return of investment. The question about affordability, I think the challenge is going to be have one piece of legislation trying to fix it all is difficult. And I think where you're facing some challenges is that when it comes to access, this is a national competence. So what we're seeing at the moment is you're probably having two schools of thought, really. So the one school is, if we give the carrot, basically, we give more regulatory data protection, then we will also be able to get access and affordability. The other school of thought is that we will basically have an economic fine. We'll basically, have the stick and punish those who are not going to, go for price and reimbursement in all EU 27. So I think it's a difficult question, and I think it's going to be interesting to see if you will be able to solve both innovation and affordability with one piece of legislation.
Where do you see it leaning, the carrot or the stick?
Probably, I would say, towards the stick. Yeah.
And why?
In the way that I think that there has been a lot of push to try not to have a de-linkage between how much protection you get and the fact if you actually launch in an EU country. So I think also for industry, some would prefer to see a de-linkage, but that also means that then there will be maybe more of a stick in the case if you don't launch in all EU 27.
Katja,
does that make sense?
Yes. A lot to consider. Thank you so much for your time.
Thanks a lot.
Valentina Strammiello joins us now to share the impact on patient outcomes. We're so happy to have you here. From a patient perspective, does the EU pharma strategy as well as health technology assessment regulation support ensuring value in healthcare for EU citizens?
That's a very complex question because we needed to separate these two pieces of legislation. Indeed, the intention is to bring value to patients and citizens in the European Union, but the methods for delivering on the expectations are not fully in line with our expectations. So when it comes to the EU pharma strategies, we welcome the intention to bring on board the patient perspectives at the European Medicines Agency, for example. We value the intention, but we are not fully convinced with the way some of the proposals have been conveyed. So, for example, they look at unmet medical needs as a definition that in our views is too narrow and doesn't really consider the expectations and needs for patients. Our view is that the patients' needs go beyond the medical aspects. They should be more comprehensive and look at more the full, and that is I would like to change, They should look at the quality of life and the way they experience and they cope with their conditions.
Right. It's just the societal impact, you know, just on their life. How would that be captured?
Our position is that through patient involvement, a lot more could be captured. Unfortunately, we have not been fully involved in the process so far. So we believe that the patients might play a major role, for example, indeed in the definition of unmet medical needs. They might play a major role in the identification of medicines shortages, because they, as the ultimate users of technologies, they are the ones who experience firsthand whether there is or not a lack of availability of medicines. So there are multiple examples within the pharma package where we have identified opportunities for patient involvement. When instead it comes to the HTA regulation, again, we see an opportunity for involvement in multiple stages of HTA. So first of all, in the PICO definition, we know that there is an intention to bring on board the voice of patients through national patient organizations and the European patient organizations. But at the same time, there will be hopefully opportunities to contribute to joint clinical assessment, to joint scientific consultations. Whether and how this will be implemented is not very visible yet, because of course we need to start the implementation process, and there are still some processes to be fine-tuned, and nothing is predictable yet. So on our side, we are working on training patients and making sure we have a large pool of patients available to contribute. But beyond that, we don't know exactly the when and how this will take place.
But in a perfect world, right? In a perfect world, if the definition was more expanded and patient voice was more heard, how would it change the patient kind of healthcare journey?
For sure, we expect this legislation to support access to treatments, to technologies that matters to patients. Of course, this requires the generation of robust evidence to support this process. On the other side, I think there is a need for more clearer support to the patients, community, to patient organizations, to make them feel part of this effort. Because at the moment we are in the stage where there is a willingness to involve, but in practical terms, we still need to see the avenues to make it happen.
Thank you so much for your insight. We appreciate it.
Thank you.
And for more insight, we're joined now by Petra Wilson. Thank you so much for being here. My first question to you is, can you give us an update on how close we are to the European health data space?
Thank you. That's a really interesting question, and I'm immediately going to have to say that that's actually two questions. So we have the European Health Data Space Regulation, which is a piece of law which is going to come in at European Union level, and it's going to create the European Health Data Space. So the first part is, how close are we to having the European Health Data Space Regulation? We are about 3 months away. So in February, we don't know the exact date yet. We imagine somewhere around mid-February 2025, the European Health Data Space Regulation, so the European law, will come into force. And that will start the clock ticking for 2 years, during which 2 years the member states of the European Union have to get their house in order to actually have a European health data space in place. So on the one hand, it's just around the corner. In February, we're going to be there. The regulation is going to come into force. But then the clock starts ticking. And that clock, for the first 2 years, nothing's really going to happen that we as researchers or patients know anything about. But it's all going to be going on in the background. 2 years after that clock starts ticking, the first elements become real. And those first elements are what is known as European Health Data Space 1, or the primary use of data. And that will allow European citizens to move freely across European borders and for their health data to follow them. It will also make electronic prescribing across borders a reality. It will mean that you can get your MRI data wherever you are in the European Union. And it will also really enhance your rights as a patient to access your data and also to contribute your own data to your health record. A little bit further down the line, EHDS 2 or secondary use of data will come into force. And this is quite far out. This is not really until about February 2029 that we will have a whole new framework to allow secondary use of data. And that's, of course, what's really interesting to people working in health economics and outcomes research, because that's when we can make secondary use of that data that is collected in order to treat patients in the first place. So we're kind of on the cusp of something really exciting, but it hasn't quite happened yet.
I was going to say, it is very exciting. Do you think enough of the infrastructure is in place to meet these deadlines?
No. I could expand on that answer, but the short answer is no. Of the 27 member states of the European Union, around 5 or 6 have the basics of what's going to be called a health data access body and a digital health agency in place. But a lot have still got a long way to catch up. And that's what that 2-year period is for getting that infrastructure in place. Now, the European Union will be making some funds available, but the reality is also that some of that money is going to have to come out of national budgets. And there's going to be debates and negotiations about that because healthcare budgets are never big enough.
Right. And talk about more broadly, how is this relevant to the broader HEOR community?
I think this is going to be a game changer. It's going to be a game changer down the line. As I said, 2029 is when the European health data space for secondary use of data will be fully fledged. And that will mean that you no longer have to go negotiate with single data holders, no more direct negotiations with pharma companies or with hospitals or with patient registries. All of that will be harmonized and accessible through a health data access body. There will be standardized ways of accessing the data. And perhaps more importantly even, you will have a much better idea of what data is available. The European Health Data Space Regulation will require all data holders to label their data as to its quality and potential use. And that will be standardized across the European Union. So as an HEOR researcher, you will be able to go to the national catalogue, find out what data exists, go to the national catalogues of other countries as well, other countries in the European Union, make one application in one member state and get the data from other countries. So I think it will be a real game changer, but that's a little bit down the line. And it's not all going to happen at once either. 2029 is when the more simple data will be available, the patient summaries, the e-prescription data and so forth. The omics data, the social data, that kind of stuff, that will be a little bit further down the line in 2031. So it will be a game changer, not immediate, but there's an awful lot, as we've already said, of infrastructure that has to be built. And we also have to really start getting used to it because it's going to be very different in terms of how we deal with patients as well, because there's not going to be any more requirement to consent or get consent for secondary use of data. A patient will be able to withdraw their data from the national pool, but the assumption will be that if you have not withdrawn your data, it's available for secondary use. So that could be a really big changer.
A lot of exciting developments underway. A lot more work still needs to be done. I'm Aundrea Cline-Thomas with ISPOR TV.